Good afternoon. My name is Joel Zimberg. I'm the director of the Paragon Institute's Public Health and American Wellbeing Initiative. For those of you who don't know, Paragon is an independent, nonpartisan health policy institute established about 3 years ago with the goal of reforming government and empowering patients. In that brief time, Paragon has become, and I think I can say this without fear of exaggeration or contradiction, the go-to Washington, D.C. think tank for issues surrounding healthcare. One important issue that we're all facing today, and we've all undoubtedly heard about, is artificial intelligence. And we've set out at Paragon to address this issue both via a paper that you're going to hear about and through the panel discussion today that's going to address all these issues in healthcare. And this all comes against the backdrop of rising healthcare costs in the United States that threaten to really swamp the government's budget and to swamp our economy, with severe impact on productivity and severe impact on all of the other things that we like in our society and that we would like to preserve without having them crowded out by healthcare. Artificial intelligence may help do that by cutting the cost of delivering healthcare while at the same time maintaining or even improving the quality of that healthcare. In other words, by improving healthcare productivity. Now, AI advocates are claiming this is a panacea. It's going to do what I just said and more, and it's the greatest thing since sliced bread. At the other end of the spectrum, you have people who are concerned about AI becoming self-aware and the advent of Skynet and the Terminators and the end of civilization. Now, as you might imagine, the truth is somewhere in between. And that's where we hope to find out today, where that truth really lies. So to do that, we are really aided by several panelists. Unfortunately, we're having a little bit of some technical difficulties reaching two of our panelists, but we're going to get started anyway. First, we're going to be hearing from Kev Coleman. And Kev is a visiting fellow at Paragon. And he's had a wide-ranging career, including healthcare research that's been cited in newspapers and media and in congressional hearings. He's the architect of the first private Medicare insurance exchange on the internet, and that was launched years before healthcare.gov came on board. And he was named by an industry magazine as one of the 20 most creative people in insurance. He's the author of that Paragon research paper that I referenced just a few minutes ago, called Lowering Healthcare Costs Through AI, the Possibilities and Barriers. And that forms the basis for today's discussion. That was issued, by the way, if you want to access it, you can via Paragon's website. Adrian Aoun is a serial entrepreneur, including most recently running special projects for Google and leading many of its AI efforts. He's CEO and founder of Forward, the world's first AI doctor's office, which is currently live in more than 5 cities and is moving towards becoming live in many more. We're going to hear from him about his experience with getting that approved and what his experience has been thus far with running that. So as I said, we're going to get going pending hearing from our other panelists, but I'd like to start with having Kev describe the paper that he published a few weeks ago and give us an outline of what he found.
Well, thank you very much, Joel. I appreciate that. And what I'm going to do at this point is just share a brief PowerPoint presentation. So I'd like to thank everyone attending this discussion of AI's potential to reduce healthcare costs. And instead of struggling to summarize a few dozen pages in about 10 minutes, I'd prefer to discuss the main concerns framing the report and review a few of its more important recommendations. So first and foremost, my investigation into the subject reflects a profound worry over the state of American healthcare spending. Back in 2009, the Social Security Advisory Board described the nation's healthcare cost trajectory as unsustainable and perhaps the most significant threat to the long-term economic security of workers and retirees. Now, at that time, the US spent approximately $2.5 trillion on healthcare, which represented over $8,000 per person. By 2022, the United States spent over $13,000 per person, totaling $4.5 trillion. This amount represented 17.3% of the nation's gross domestic product. In comparison, the US spent only 6.2% of its GDP on healthcare back in 1970. Now, our exorbitant healthcare spending must be further considered in the context of our national debt. As of June of this year, the US Treasury Department says it costs $868 billion to maintain our debt, which is also 17% of our federal spending. These are not encouraging numbers, and I agree with the Social Security Board that they are unsustainable. Moving back on to the economics of American healthcare, a second issue influencing my thinking is how the lack of traditional market forces have prevented other logical and well-intentioned cost reduction efforts to succeed. To appreciate the absence of market forces within American healthcare, consider how Americans pay for medicine. Insurance accounts for approximately 90% of hospitals' patients. And with insurance, predetermined payment rates are negotiated between health plans with healthcare providers. This model does not lower payments based on localized deficiencies within a provider network. Likewise, medical practices have no incentive to lobby health plans for less compensation in circumstances where their costs lower, whether by AI or other means. So let's consider something like administrative savings in this context. As you'll see within this larger discussion, a lot of my focus is not on AI in general, but a specific subcategory, autonomous AI healthcare. So going back to administrative savings, it would be reasonable for an AI vendor to claim that a medical practice's labor could be reduced through something like patient intake kiosks and back office claims automation. But why would we expect these savings to reach consumers? As discussed, most of a patient or most of a doctor's rates are determined by rules of a health plan. If artificial intelligence lowers a doctor's admin costs, that doctor won't request the practice's insurance payment be lowered. This would penalize a doctor for being more efficient and effectively reward doctors who didn't risk investing in AI. Now, the same problem repeats itself across a wide dimension of scenarios, including productivity savings. For instance, if an AI system can increase the speed of medical image reading, a hospital is not going to request lower payments. Turning from provider to consumer, insurance itself conceals the full price of medical treatments. Patients typically pay the same out-of-pocket costs regardless of in-network doctor choice. And thus, insurance removes the financial incentive to compare prices and select the best value. The absence of service shopping, in turn, diminishes price reduction as a basis for doctors to attract and retain patients. These circumstances account for my interest in autonomous AI healthcare and its future possibilities. With the advances made in large language models, generative AI, and machine learning, we've entered a period where unassisted interactions between patients and computer systems can become more sophisticated and capable of consumer self-service. Prior to AI, decision systems often relied on ornate rules-based decision paths. If you're a programmer, think a lot of if-else statements. AI, in contrast, brings data-driven reasoning and introduces the prospect of occasionally eliminating one of the great cost drivers in American healthcare, human labor. Now, let me emphasize the word occasional here, so no one thinks I'm saying autonomous care would be applicable to the entirety of the medical landscape. I don't think it would. Labor, however, is a major cost driver in American medicine. A 2018 study concluded that labor and goods costs were the leading reason for high U.S. medical costs as compared to other high-income countries. Medscape's 2023 Physician Compensation Report found the average primary care salary was $265,000 in the U.S. and $382,000 on average for a specialist. 2024 data found the top 5 highest average salaries among medical specialties were each above $500,000 annually. So, autonomous AI systems providing a medical service under the right conditions could bring some traditional market forces into our healthcare landscape. For example, they could advertise their prices and compete for consumers with high deductible health plans, the uninsured, and employers that self-fund and have a financial interest in lower provider costs. If you're wondering why I'm not saying all insurance plans, there's a bit of a conflict of interest that comes in for commercial health plans with what's known as a medical loss ratio, subject I won't treat at the moment. Now, going back to the an autonomous AI system, it could operate on lower margins given the advantage of aggregating customers across state lines. Moreover, one of the great advantages of software in general is that it scales with low marginal costs as compared to the models that depend on human labor, where doubled capacity is doubled staffing and doubled cost. When we consider access to AI-mediated care, you not only have the possibility of retail locations, as CarePods does, but also cell phones and computers connected to peripheral devices that can gather diagnostic information. Now, when you consider the economics of provider visits versus autonomous care opportunities, you could conceivably have a health plan pay for some of those devices and still save money on the in-person care it eliminates. We're seeing something roughly analogous to this beginning in the dental insurance market, where one insurer is providing its consumers with an internet-connected toothbrush that's collecting brushing data. With this said, autonomous AI's potential for reducing healthcare costs has serious obstacles to overcome. Perhaps the first issue is that healthcare AI development is not focused on the matter of autonomous applications. Its clinical applications are often in diagnostic work such as radiology, pathology, and dermatology. In fact, more than 80% of the 692 AI medical algorithms cleared by the FDA through July of last year pertained to medical imaging. Another challenge around autonomous AI is how effectively it will be regulated in the US. Now, the FDA does have years of experience regulating software as a medical device, having developed a framework for risk categorization, quality management, and clinical evaluation. AI, though, presents some new complications compared to traditional software. For example, how would we deal with a system which improves itself beyond the training data through use of its ongoing real-world results? One of my concerns around getting regulation that properly balances safety and innovation is the possibility that lobbying groups will advocate that all AI healthcare be supervised by a clinician, dooming AI to be an incremental expense on an already expensive healthcare system, even in instances where an AI system can empirically demonstrate that it can safely eliminate clinician contributions without negatively affecting quality. Now, to avoid that, I recommend that the FDA have an explicit approval pathway for autonomous AI healthcare devices that would verify, among its other evaluations, that the system's accuracy levels are equal to or exceeding the average for clinicians performing the same function. Additionally, an autonomous AI system must not amplify health risks. Now, given the continual evolution of AI software systems, it is also advisable that regulators provide an economical pathway for innovators to reapply for FDA approval on their devices where the functionality remains the same, but the system autonomy increases over time. On this front, the FDA could leverage work already performed in the US by the Department of Transportation for self-driving vehicles with differing levels of system autonomy. For instance, driver assistance versus self-driving. Turning from regulatory considerations, AI's potential to affect healthcare savings is also a matter of intellectual property. IP protections preserve the incentives for research and development investments, but these same protections, if misapplied, can inhibit innovation, as well as encourage the use of AI patents as legal weapons to bleed funds away from AI startups. As a former startup executive with a couple exits, I remember quite well what it's like dealing with patent trolls. Now, to discourage this latter scenario, I would recommend that the Patent and Trademark Office promote a mild skepticism around process patents without disallowing them altogether. In this scenario, we would favor trade secrets as the preferred method of protection when an algorithm claims are heavily indebted to existing theory and practice in the AI field. Now, before we move on to questions to the panelists on AI and healthcare savings, I'd like to share a few final thoughts. One of them is that even with a reasonable regulatory and intellectual property environment, extracting healthcare savings through autonomous AI, I think, needs a major sponsor, whether it be a university project or government project. I believe this is necessary not just for urgency, but to approach our healthcare systematically, as opposed to searching for opportunistic point solutions. A major project would also prioritize autonomous AI solutions based on their financial value and its contribution towards reaching a predefined savings goal. Now, this might be done in the service of a major insurance program like Medicaid, or it might be in the context of a project seeking to expand healthcare access in regions of the world lacking adequate medical staffing. One final issue I should mention is that obviously there are significant savings opportunities outside of autonomous AI in healthcare. For example, AI detection of fraud, waste, and abuse on large government insurance program has the capacity to save billions. Likewise, given that about 5% of people will account for about half of healthcare spending, AI tools could optimize provider choice and treatment guidance using its data on pricing as well as predictive models, and then also leverage that to request bundled pricing. So with that said, let's now turn to some of the questions Joel has for us as panelists.
All right, thank you, Kev. I appreciate it. I want to point out to everyone we've overcome the electronic barriers that are impeding our intellectual endeavors and added one of our panelists, Dr. Mark Sendak. Dr. Sendak is the Population Health and Data Science Lead at the Duke University Institute for Health Innovation, where he leads interdisciplinary teams of data scientists, clinicians, and machine learning experts building technologies to transform chronic disease management and improve clinical care. He is a co-inventor of software to scale machine learning applications and real-world evidence generation across health systems. He also co-leads the Health AI Partnership, which is a learning collaborative to advance the safe and responsible use of AI. And I would welcome my fellow physician to the call. Too often we have these discussions about healthcare policy without actually involving people who have MD after their name. So welcome, Dr. Sendak. So I'd like to turn to the two panelists we have, Adrian and Mark, if you can tell us your reactions to Kev's presentation and sort of step back for a minute and just give us an idea of what you think the real world possibilities in sort of immediate term for AI making meaningful improvements to healthcare productivity.
Mark, do you want to start?
Sure. So maybe I'll start with just a reflection of kind of some of what Kev pointed out, I think is very insightful in terms of how we pay for healthcare today and how we assign monetary value to interactions. It reminds me of when I first learned about RVUs and how RVUs are assigned and weighting of procedural specialties. And so it seems obvious now when you point it out that, of course, when you can start to automate some of these things and they require less physician work and energy, that would not align with the current payment structures we have. So you would not see the cost saving. So I really appreciate that perspective. I would say that where I see promise, a lot of that comes down to the types of uses we see in practice, both at Duke internally, as well as across the network of sites that we work with. So there's a lot going on clinically in terms of improved decision-making, diagnosis, population health management, remote monitoring, as well as operational efficiencies, scheduling, inter-hospital transfers, allocating resources like ICU beds, ECMO, ventilators. So I guess at a high level, we see both clinical uses for specific decisions. We see clinical uses for allocating scarce resources that are in demand from populations and patients in the hospital and outpatient settings. And then really large language models have opened up an entire different set of use cases where we can do things now in the course of hours, days, weeks that years ago would have taken much longer and would have not been feasible. So I would say it's a very exciting time, and you do see a lot of health systems increasing their adoption and investment in AI.
Yeah, I think maybe just to add on to that, but I think a lot of what you're saying is right, Mark. The way I think about it is, when you look at something like AI at its core is just a tool, right? But it's a tool that's so transformational that you have to kind of start to reimagine the primitives that it was built on top of, right? When we started coming out with like the first cars, people didn't go up to their horses and say, I should attach wheels to my horses. And some people did, and it turns out it didn't get them very far. It was called chariots. And then at the end of the day, they were like, wait a minute, maybe we should just, actually ditch the horse and build this thing called a car. And what we have today is the core primitive of healthcare is that healthcare is kind of a service, right? It's doctors, it's nurses. Now, I love doctors and nurses, but the reality is that you have an opportunity to rebuild healthcare more as a product, right? When you go to your Gmail, you don't think, oh, I'm sending an email and somebody in the back office is going to take that email and put it in a different folder in a different folder. You just go, no, there's a bunch of people working on Gmail, but what are they doing? They're writing the product and they're deploying it out to millions of people. In the old world, we call that, I think, what Mark Sendak said, which is like, hey, I do population health. Well, what does population health mean? It means that he's trying to affect not just one life in front of him, but he's trying to affect maybe thousands or millions or maybe one day billions of lives right in front of him. And that impact is something that we can finally start to do because we have technology, we have tools, we've gone from, building the wheel to now building AI. But for this to work, we can't just attach it to the existing system. So we keep asking ourselves, well, can I, insert AI into this one little part of what a doctor is doing, or insert it to kind of assist the doctor here? But if we do that, we're just going to kind of keep, throwing good money after bad. And so what I would encourage us to do is start to just say from a clean slate, like, what would the world look like if AI was already here and it was already safe and it didn't hallucinate and it was ubiquitous and it was free and it was regulated, et cetera? And what you're going to start to iterate to, and now I'm going to sound like the little techie nerd, so picture me with some big thick glasses and a pocket protector. But you're going to start to imagine what you used to, read in your sci-fi books or watch when you watch Star Trek. I remember when I was growing up and I would watch Star Trek, they had this thing called the med bay, like these tubes, these rooms that you could go into. They'd give you all your diagnostic. They'd give you the answer. If you needed a treatment, the lasers or whatever they would just treat you. And all that sounds a little ridiculous, right? But I would start to ask, is it really ridiculous? Like, are we really that far away? Because the one delta, like, we've got lasers, we've got devices, we've got scanners. The one delta is that today we trap everything behind a physician or a clinician. And I would encourage us to start asking ourselves, rather than putting the clinician in between us and the product, just let consumers access the products directly and put the clinicians on the other side building those products. Let's give them the AI tools to go build the algorithms and build the treatment protocols. And if we do that, we can start to get to a great new world. What concerns me is that when I look around at how most healthcare systems are approaching this, or when I look at kind of the regulatory environment, it's truly trying to kind of update the old world as opposed to reimagine the new world. And I think that's kind of a local optimum. And I think we're maybe missing the forest for the trees.
If
Okay,
I may
well,
jump in just to comment on some of Adrian's points, and I want to thank both panelists. Those were both very insightful comments. What Adrian said reminds me of discussions I have had with reporters over the years. Inevitably, you know, being an interview and a reporter will ask, well, you know, why is American healthcare so expensive? And I say, well, it costs just about as much as you would expect for, you know, the level of competition or population health or level of regulation, you know, et cetera. In other words, it's a tautology, A equals A. And that we, as we envision a less expensive healthcare, we should be envisioning something that doesn't necessarily look identical to what we have now. And I think Adrian did a very good point on that, as well as Mark talking about the expansive touch points that he's seeing in terms of AI application at Duke University and its health system.
Mhm. So I want to remind all our viewers, by the way, that there is the opportunity to ask questions, and we already have several questions. And I'm actually going to work one of the questioners' questions into my commenting on, I think, primarily what Adrian said, but what we've all said, and try to move us along. This person asked, in what ways are we already using AI in healthcare? Many people are unaware that for many years now, we've had various programs. We wouldn't necessarily call them AI, but they're kind of computer-assisted diagnostic programs in image identification, things like, for example, helping computer-aided diagnostics for mammogram reading. So we've had that experience, and sometimes it always hasn't been a happy experience. And that kind of leads us into the next question. I mean, I think you've all identified the idea that the best way is turn this into a product, as Adrian said, and then physicians will be part of the product, but maybe in the what Kev is pushing, or autonomous AI, they won't be a very big part of the product at all, and it may be done in a way that is attempting to exclude the need for there to be physician input. So I want to narrow the field a little bit and say, what has our experience been thus far? And what do you think the prospects are for what Kev is really has as a focus of his paper and the presentation you heard, this idea of autonomous AI, which greatly lessens or maybe even eliminates the need for human input?
Yeah, maybe I'll start. So actually, AI is being used in drugs. I mean, it's being used everywhere in healthcare. It's just being used on the non-patient facing side. I always like to remind us that all the innovation, I shouldn't say all, but let's call it 90% of the innovation that we have in healthcare is financial innovation, right? Because it's the least regulated, and it turns out there's a lot of money to be made. And so what we do is, I mean, if you're a doctor today and you write up your notes and you submit it to the team that's responsible for getting the billing codes attached, dear God, there's a lot of AI looking over those notes going, oh, I can attach this billing code and this billing code, and wait, there's an extra $3 in here. But I would just kind of pause and ask, like, is this what we want? Like, is this good for humanity? No, of course not, right? So again, if you just kind of take a step back and you ask yourself, like, if I came to you and I was like, oh, I just think healthcare should be roughly $0 for everybody. And I don't mean like, oh, the government's just going to pay for everyone. That I don't think shifting who the payer is makes that much of a difference. But if I said I truly want it to be like actually so cheap that we don't even think about it again, you would say, well, that sounds a bit ridiculous, Adrian. It's like 17% of GDP, right? Like, and it's growing. I think it's doubling every 10 years. Like, how are you going to get there? But remember, like, we had this problem in other industries. Like we used to sit there and have libraries. When I was growing up, I used to go to the library all the time. I was a big nerd and I loved libraries. And I remember reading this thing once, it was like, oh, well, you know, these starving kids in Africa, they don't have libraries. And I sat there and I was like, I'm going to work to get libraries to every corner of the planet. And then these two guys named Larry and Sergey came along and were like, you idiot, we're just going to build a search engine. And now we have libraries for the whole planet. Like, we've democratized information. It's so inexpensive to have access to information that we don't think about it anymore. But when you look at healthcare today, like, why are we not there? Like, what is the limiting factor? Again, from first principles, let's ignore a little of how the industry is developed, but just from first principles, when you're going, like, what is the thing that is so expensive? I always try to remind people, like, so my brother a few years ago had a heart attack and he had to go in and have some surgeries and all this stuff. And I just remember, you know, there was like $100,000 worth of bills. And I was just looking and I was like, well, what did we pay for, right? Was there, like, if you go in and you get open heart surgery, right? I mean, is there like some, I don't know, some platinum? Is there some uranium being used? Is there a $5 million machine? No, it's kind of a dude with like a fork and a knife, except they call it a scalpel and something else, and they're cutting. I mean, where did all this cost go? And what you realize is we bloated the system. And the big fear that I have today, and I think unfortunately the fear is being realized, is that we're starting to use these technologies to continue to bloat the system, as opposed to say, let's rethink it and let's just get that healthcare to be a true commodity that maybe nobody makes money off of, because you know what? It's so uninteresting. There's so few dollars working through healthcare. Like, imagine that, how great that world would be.
Mhm. Mark, do you have a retort to that or a comment? I think you're on mute, Mark.
I feel like I have a different perspective where maybe I'm more colloquial in my thinking, being part of an innovation team within a health system. But we definitely, I would say that I would not overlook the use of AI in clinical care and clinical decision making. I think that there's a lot of emphasis on administrative and back office functionality, but, and you know this, Joel, quantitative tools for diagnosis, triaging have been used for decades in medicine. Decisions around when and how to prescribe medications, they're getting more complicated. They're being introduced for many more diagnoses. I think that, and Adrian, I feel like we'll need to get like a beer. This is like a conversation over beer of, I live in a world where we drive innovation within the system, and it's to solve clinical and operational problems that are identified by our frontline workers that align with the strategic priorities of our senior leadership. So every year I see dozens of potential opportunities to use AI to solve problems for frontline clinicians. Sometimes it is a case where a frontline worker doesn't want to be involved in something at all. So, for example, we have 2 projects this year for large language models tackling prior auth. There's a whole lot of frontline clinicians who don't want to have to get on the phone and argue about prior auth.
Yeah.
They would love for that to be entirely delegated to autonomous systems. There's other cases where the clinician, whether it be a physician, pharmacist, nurse, wants to delegate some amount of a task or responsibility. So the other thing, being part of a health system, I feel as responsible for safety, quality of the care that we deliver with the tools that I help build as the clinicians we employ. So I would say that there's not many cases yet that I have worked on where we keep the clinician in front of the technology when we confidently think the technology performs better than the clinician. So I know those cases are emerging, but there's still a lot of things, and that's where I think things working within the system, especially at a place like Duke, we don't want to build something that's just going to sit on a shelf somewhere. So there's a lot of change management involved with frontline folks who think they're the world's expert on something. Joel, you've worked with many of these people, and it's going to take some time to get them to buy in, to gradually kind of leaning more on what these tools can become capable of.
Yeah, so
Yep.
let's just kind of come back to the beginning of the thing you said. You said, hey, and I'm going to paraphrase, you said, hey, we build things that the clinicians want, that our management wants, et cetera. But, and I'm going to say this with all due respect, but you didn't say what the customer wants. You didn't say what the patient wants. And at the end of the day, if we take that approach, we're going to build the wrong product. We've seen this time and time again, right? When I was growing up, we were so excited. We got these things called BlackBerries, which the IT department wanted. And then eventually Apple was like, we're going to build the iPhone, which is what you actually want. And oh my God, am I happy that happened. But like, let's just take a step back. You said, hey, I don't see this scenario happening often where consumers could go do something directly without the clinician, but yet we're you know, unnecessarily including the clinician. Sorry, am I?
No.
You look on your face.
Yeah. I was going to say, what I said was, I haven't seen the scenario where we build a technology that outperforms a clinician that a patient could use directly, but we keep the clinician for some reason to just keep their ego like respected.
Okay, well, we should acknowledge that that's just factually inaccurate, unfortunately, right? So, I mean, all sorts of things. You know, during COVID, I couldn't get a COVID test for the first whatever 6 months without a clinician sign off, right? Like, how ridiculous is that? I went the other day to get an MRI, and this was really great. At the end of the MRI, I'm like, okay, can I have the CD, DVD, USB, whatever it is? And they go, nope, we're going to send it to your doctor. And I'm like, wait a minute, why? Like, am I going to hurt myself by looking at this MRI that I just paid for, right? Like, and what you realize is that the incentive of the industry is, of course, to ensure that that people, that the labor, the clinicians, the people that can bill, are kind of inserted into every segment thereof. In fact, I run a healthcare system, and I will tell you right now that if you come into my healthcare system and I would like to give you an EKG, I need a prescription. I'd like to give you a blood test. I need a prescription. Like, what? Like, how absurd is this? Like, why do I need a prescription? What information is that doctor gonna use? But clearly what we have is we have this thing called the AMA, the American Medical Association, which is roughly like the taxi medallions were to Uber. It's this world where they're sitting there saying, hey, I just want to continue billing all the time. And I think that we need to kind of figure out a way to move to a new era where we're putting the patient first and not actually the clinician first. The same way that Google isn't building Gmail for the engineers, Google's building Gmail for the customer.
Well, Adrian
I
and
think-
Mark, can I ask you guys a quick question? Just because this was one of my points within my discussion, is that I don't believe that a serious bend to the healthcare cost curve, particularly with AI, will happen without a major project because of what Mark was touching on. And I describe it as opportunistic point solutions. And by that, I'm kind of putting my startup hat on and saying, okay, I see a sub-optimization. I have existing technology whose functionality I know can improve the situation. I build this. What I'm saying is that we actually need a project that takes a look at a health system as a whole and analyzes it for its inefficiencies and where the kind of emerging strengths of AI can massively change costs. Going back to Joel's point, because I know I'm going to get criticized on this, I'm going to be accused of wanting to get rid of doctors. I don't, the issue won't be of doctors being eliminated, but their roles over time will transform, just as mathematician roles transformed first by calculators and then by significant software computing systems. Still have mathematicians, but they're doing different operations within the system as a whole. So anyway, I just want to kind of jump in and say those things because in some ways it touches upon what I feel is a necessary thing. We need some kind of moonshot project, whether at the university level or at the government level, that says, okay, we need to drop healthcare costs by 20%, which, by the way, is 900 billion, correct? If we have 4.5 trillion, if I'm doing math correctly in my head, that requires profound thinking and systemic thinking, not point solutions, in my opinion.
So Kev, you mentioned whether it's by the government or by a university or I suppose a private entity. And I think that may bring into some relief I think disagreement a little bit between Adrian and Mark about the role of professionals or physicians in the future system. Adrian, you're describing a situation where you want the consumer, the patient, to be able to access care that they want and the way that's most convenient for them, that they think is most efficient. And I suppose that would include a patient decides I need an antibiotic, I need surgery, and if they decide they need it, and then utilizing the help of AI, that should be adequate. Which it sounds like. Well, you said like, if I want an MRI or if I want an EKG, why shouldn't I be able to get it?
Yeah, but that's pretty different than surgery, right? An MRI doesn't hurt me.
Oh, well, that will take something
we made a
intermediate.
logical leap that I don't ascribe to.
We'll take a heart medication or an antibiotic or chemotherapy.
There's a very particular reason I didn't use those, right? So I want to be clear that we shouldn't put words in my mouth on this. Now, what I do think, let me be very clear, is that I am not trying to eliminate clinicians. I want twice the amount of clinicians. I want 10x the amount of clinicians. I don't want clinicians to be day laborers, right? It's like today, being a doctor is roughly being a cobbler, right? A new pair of shoes comes in, you fix it, you send it on its way. The new patient comes in, you fix them, you send them on their way. But you're going to get the same pair of shoes tomorrow and the same patient tomorrow. You're not solving the root issue. I want to move to a world where we give doctors tools so that they can sit there and say, I don't want to see the flu ever again. I know that people are going to have it, but we've created the protocol. Here you go. Boom, we're done, right? And that's how we build products, right? We look at any single circumstance that we need to get involved from a human perspective, and we say, that's probably a bug. Can we automate our way out of this? Can we empower others? Now, that doesn't mean that you abdicate the responsibility of building responsible tools, right? There's a lot of things that can go wrong in your Gmail account that Google has to think about. People can be trying to steal your passwords, they can be trying to fraud someone else, et cetera, and that's their responsibility. So I do not think you should just say, hey, choose any med you want, have fun. Like, that would probably be a pretty bad idea. But that's different than saying that we shouldn't give people the tools to make the right decisions, to come to the right conclusions. And that's what we're trying to do at Ford. But frankly, that's what everybody in the population health world is trying to do. They're just trying to do it with immature tools.
So I think there's also the matter of trade-offs, Joel, where I think the way you approach healthcare and AI is very different if the fundamental question is, how do I create insurance that only costs $125 per month per person? That then sets up, an intellectual framework to analyze claims, procedures, administrations, regulation, et cetera. And that's what I'm looking for in terms of something transformative.
Right. So Mark, you look like you had a...
Yeah, because Adrian, I want to go back to, are there immeasurable processes that introduce efficiencies for patients being able to access care? The answer is confidently yes. That happens.
Immeasurable, you said?
Like I can't even measure the number of inefficiencies that are introduced into patient interactions. You gave the examples of being able to get a scan, being able to get an EKG. All of that is true. I think the point I was trying to make is you build an algorithm, you evaluate an algorithm. You can evaluate an algorithm's performance to the status quo, which in many cases will be human decision-making. You can evaluate an algorithm to other algorithms and other products. It's in scenarios where algorithms do outperform human decision-making consistently, I think it's fully responsible to be able to delegate human decision-making to algorithms. But I don't want to convey that is a very common occurrence today. Will that change? Yes. 5 years from now, will the number of tasks that a human can perform more accurately than an algorithm diminish significantly? Yes. And I think we have to be really responsive to how the technologies are changing. But it's, at least today, I think that we're just starting, we're anticipating this change.
I think that we are destroying the change. And I think the reason that we're destroying the change is almost exactly kind of and I'm going to pick on your phrasing, so I apologize. Please don't take this personally, but you said like we should delegate to the computers. And it's like, well, I don't know how to say this kindly, but computers are a hell of a lot better than us these days at almost everything. Not everything, but almost everything. So let's start by saying, hey, let's have the computer do it, and let's delegate to the human when the computer can. Hear me out, right? So the way, for example, we design and build the forward healthcare system is we start by saying, presume a computer can do everything. We know it can't, but let's presume the computer can do everything. And then whenever we're kind of watching it and go, oh, that's a bound that, you know what, computers aren't good at yet. That, you know, by the way, empathy is something computers are pretty bad at these days, right? Then we escalate to the piece of technology, or sorry, to the human, the clinician. We escalate out of the technology. But I think if we start by saying, hey, the labor, the humans involved, whether it's on the billing side or clinicians, are the ones that kind of do everything right, and we're only going to delegate, then we're going to end up in this world of point solutions for quite some time. It's really hard to make progress.
So I want to, oh, Mark, you had a...
Yeah, and this is just the rhetorical question, which we're not going to answer today, but we're approaching this from different vantage points of, show me a computerized health system that provides quaternary care at the level of Duke and its peers. And those are the problems that I work on. So it's a different viewpoint. Sepsis, cardiogenic shock, ECMO, these high acuity complex conditions, transplant. These are things that I can't confidently say computers do this better than experts today. So it's just a different set of...
I agree. But my fear is that we are not trying to build towards that world.
Well, I think you're both agree. I think we have agreement here that maybe you disagree on how far we've come, but I don't think you disagree on where we may be going.
Yeah.
And I think one question that's come up in some of the questions, and it sort of plays into something I was curious about, what do you see as the barriers to us moving in that direction, whether they're regulatory, whether they're some of the professional sort of cupidity that I think Kevin was talking about earlier. What do you guys see as the barriers to us moving in this direction, where I think we all agree there's tremendous progress to be made?
So I don't claim to be the expert on this. I'm a lowly engineer, but what I think I see is kind of two things that really stop the world from progressing in the direction that I hope it would. And the first is regulatory, and the second is financial. Both of them encode the existing system the way that it is. So when I ask myself, like, why is there not a Google of healthcare, right? Like, why has that not come about? And I'm not saying it's going to be Google, but like, why is there not, like, why are tech companies not able to co-build? You know, why is Mark correct when he says, hey, there's like, look at the tech in quaternary care, it sucks, like, it's pathetic, right? And like, I know I'm putting words in your mouth, I apologize, but like, I agree with that sentiment. And then I started to ask myself, well, what the hell happened here? Like, you know, tech is attacking every industry and it's taking over the world and all this sort of, and by the way, healthcare, it's just hasn't noticed yet. Like, that makes no sense. But what you realize is the regulatory framework, kind of as we've mentioned, is incredibly encoding of the existing notion of everything works through a human. So what you're doing is you can build tools for humans. That by definition is going to cause you to not be able to make a leaps and bounds change. And then the second is that the financial kind of model in healthcare today is mostly around this kind of fee for service billing. In some cases, you can kind of get some value based, but it's very kind of short term, et cetera. It's not really about what does the consumer and what does the customer want, which is frankly where the world should be. Now, I'm not saying I have the answers on how to solve both of those, but I think it seems pretty clear that those are two of the very large kind of inhibiting factors.
Mark, your thoughts?
Yeah, and I'll try to like steer towards the optimism. So until 2 to 3 years ago, most technologies I had seen or been involved in building were point solutions. And these were very task specific to diagnostic or therapeutic decision making. And this, once again, is my bias. I work mostly on the clinical uses, so not the back office functions. And those, because they were so narrow, I think really did continue to elevate the importance of the professional workforce. I think that we're starting to see much broader applications. And the fact that we struggle to think of an indication for use for a large language model, I think is a good thing, because our historical mindset of technology innovation really has been narrowly defined by indications. But now we see these emerging technologies that can perform well across many use cases. And that's where I think that it's going to broaden how we deploy these tools broadly, so that they're not so task specific, and we can provide like additional layers of support that are more horizontal versus focused on these verticals, which is, unfortunately, healthcare is very structured by these vertical silos. So I'm hoping that some of these emerging technologies can change that.
Well, is the problem, so you both talked a little bit about regulatory barriers. Is the problem that we have regulatory barriers imposed by the government? You have an FDA that requires review, as Kev talked about earlier, of the software-assisted devices that you have. Now you've just had a reorganization in HHS that's talking about greater input into the use of AI and other healthcare technologies. Is that the barrier, that they are imposing these artificial limits that are sort of, let's say, mired in the past, as opposing to letting the market and people like Adrian move forward without that limitation?
I don't think so. Let me give my opinion here. I'm not saying this is fact, but I don't think that the issue is that we have regulation. Like, I think you want some level of regulation here. To be clear, I think it's that the regulatory frameworks that we're using are ones of the past. So let's just pretend that when, I'm going to keep using the Google analogy. So let's pretend when Google was coming out, somebody said, hold on, we're only going to let you launch as you prove that each query is as good as if I were to read a book at the local library. Well, that's not how Google works. You kind of need a new framework, right? Google does not think about each query result separately, right? They think about this algorithm overall. It's got some good, it's got some bad, frankly, it screws up sometimes, but it's pretty good overall. And I think we're all happy that we've moved from libraries to using Google. I don't think any of us want to go back to that world, right? Now, that doesn't mean that Google has no regulation. Google has tons of regulation that says, what can you put in these results? What can't you put in these results? Who do you need to downrank? Who do you need to uprank, et cetera? The problem is, let's look at the FDA, where we say software as a medical device. Well, software is not a medical device. Like let's start there. Like, why are we trying to adapt it to the old framework, right? Why don't we try to adapt it to the new framework, right? Or to say, kind of.
Well, what should that new framework be?
Yeah, and I think this is where it's actually really difficult, because, and I'm not a policy expert by any stretch of the imagination, but let me characterize the problem. If you think about it on kind of this, exactly what Mark was identifying earlier very, very properly, which is, hey, we're going to take an indication and we're going to look at each individual indication and say, did it meet the standard of care, et cetera? And if so, we're going to approve it for that. But that's not actually how we approved the doctor, interestingly, right? The doctor isn't approved on the doctor is approved globally. And you know what? If I look at a doctor and I look at an LLM, and I'm not equating the two by any stretch of the imagination, but let's just pretend I did that. Well, you know what? There's some things the doctor's going to do better, some things the LLM's going to do better, et cetera. And we took kind of this holistic view, and you can go find all these kind of scores and competitions of tons of kind of independent bodies that have put these online, but actually they say, you know what? The LLMs are doing pretty well. Now, I think that's very different than actually delivering care. So I don't want us to go make the leap that like LLMs are at the level of, being the doctor tomorrow. I don't think that. But the point is, you need a new way to kind of look at these things. I'm giving you one potential solution, which is look at the overall performance. Maybe that's right, maybe that's wrong. But certainly I'm fairly certain that the existing way of doing it seems to be pretty unwise.
Well,
Mark, before you
software, if I could just jump in for a second, is that it enables possibilities that require a different paradigm than we're used to, like say in prescription medications. You might have a provisional approval of a medication, but there might need to be, kind of ongoing post-approval data from the marketplace. And that way, you have to set up studies and gather people, et cetera. With software systems, we have log files. We can capture so much real-time ongoing, outcome effectivity data that's, an interesting thing that often is not reflected, let's say, within our regulatory apparatus. But I think, I'll be the dissenter here from Adrian. I think one of the biggest issues is not regulation per se, but that we don't have, kind of a mission critical thrust that we need to reduce our healthcare spending. This is just something that's endangering so many other areas of our priorities, like spending on education, military, et cetera. This has to change. And it has to change for economic welfare, because in the private sector, too much of our money is being spent on healthcare rather than, being invested in the, development of, new products and new services. So.
Well,
I'll
that's a good point, because we only have a little bit of time left, and I did want to segue a little bit into something, Kev, you mentioned earlier about we need a sponsor for this, and you've been very explicit. You think that AI development, and particularly the cost savings that we could generate from AI, needs explicit support, and I think it ties into the question of regulation and where we're going. Who is going to provide that explicit support? Is it going to be the government? Is it going to be the market, people, private industry looking to save money because they're just as hamstrung with economic costs as the government is? Where should we be looking? And should we be taking the kind of a free market approach, or taking maybe the approach that they take in Europe, which is quite different? So I'd like each of you to answer that, and try to do it in just a minute or two, because
I'll be very
pressed for
quick on this
time.
one. I think, given the systemic issues that come into play, and I think Adrian did a very good job in terms of touching upon a framework that just amplifies cost. We really need something that's probably at, I think, either the government or academic institutional level approaching this, because you have to go through kind of mounds of claims data, regulation, law, state laws, et cetera. And that, I think, needs serious sponsorship. Otherwise, because a VC is not going to take that kind of risk. It's too broad, and it has too many dependencies on third parties. Like, well, okay, you want to do all these things. Will the state of California allow you to, which represents 20% of your marketplace? So that would be my position.
Adrian, Mark, what do you guys think?
So I think that health systems can and need to invest more in internal R&D. I'm privileged to speak from that perspective. We're an internally funded R&D shop that builds technology and clinical care delivery models for the health system. That's incredibly rare. If you look at other industries in terms of R&D spending on their own products and services, it's single-digit percents, double-digit percents, but most health systems actually do very little of that investment. So I think we are uniquely positioned to build some of these technologies that we can immediately implement into patient care.
Mm-hmm. And Adrian?
Yeah, I don't know that there's like only one way to go about this by any stretch. And frankly, I think it might need many ways. But the world I'm familiar with is, I run a venture-backed startup. I'm not convinced that venture isn't willing to take the risks. I am fairly convinced that the risks don't make sense right now because there's not the room to kind of innovate anywhere near as much as we need, which is why I would push on the regulatory and the finance and kind of the reimbursement side. I think if we made a little more room there, then I think the venture world might actually get very interested very fast. I can't promise that, but I think there's probably a combination where you likely need some notion of government support for it. Like when I look at like, oh, we went to the moon and we came up with the vaccine for COVID, et cetera. Usually it's kind of the combination thereof. It's creating a bunch of incentive and then letting the free markets kind of go after it. I'm certain that the one thing that I'm pretty sure of is that if you want an enormous amount of people to go after this, you're almost certainly going to need like the free markets to be at play. Like, if I look at Mark at Duke, like, I don't know how many people you have working on the innovation side, but if I were to compare that to how many NVIDIA has working on chips, like it's orders of magnitude. And so you want to be able to create an incentive for companies to go after it.
Okay. Well, this looks like a conversation that could probably go on another 2-3 hours. Unfortunately, we're confined to the 1 hour that we set out, and that our panelists have been kind enough to give us their time and share their insights for. But I think, as you can see, we're interested in this at Paragon. It's one of the many things we're interested in. We'd like to continue the conversation. Hopefully, you will tune into Paragon's future events, and you can look at our publications and see some of the videos from our other events at our website. And I hope you will continue to follow us. And this is a conversation that I hope we can continue in the future. So thank you very much, Adrian Aoun, Dr. Mark Sendak, Kev Coleman. I'm afraid we have to sign off, but thanks again. And thank you everyone who listened in today for your help and participation.
Thanks for having me.
Thank you very much.
Hey guys.
Bye-bye.